afternoon and welcome to United TV. My name is Kemal Erkan. Today is July 19th, 2024. Today we have another special session focused on exploring different types of bariatric surgery. Whether you are considering bariatric surgery for yourself or for your loved ones, this is the episode for you to learn more about different bariatric surgery types. As usual, we have Dr. Isaias Irgau with us. He's one of the most experienced bariatric surgeon, not only in Delaware, probably in the United States. Dr. Irgau is giving his clinical insight and making sure that what we have today, what we are discussing today, is all coming from the clinical base. And I will be helping him with some of our questions, and we'll make sure that you have a good understanding of what type of surgery you should be getting if you are considering bariatric surgery. Dr. Irgau, we turn your camera on. Now, today is a special day for us because it's the first time we do this together in the same room. So it is a little bit different, right?
Great.
Great. I'm used to having him on the other side of town. But today he's in our studio in our new office. So we are kind of lucky to have a very nice studio here. So, Dr. Irgau, how are you doing?
I am doing fantastic, Kamal. This is just a great setting. I'm very happy to be here for yet another Bariatric Friday.
So, Dr. Irgau, this is our new cycle as well. So we have done so many full cycles, and this is the first episode. It's not easy to cover these from different perspectives, but somehow we are able to manage that. But what I did for our patient, we put these same topics in one playlist, so they can actually watch maybe 5-6 different bariatric surgery types videos. Just going to the playlist and then just do that, and they don't have to necessarily just watch one or two. They can do the whole thing. So, but just to have a background in different surgery types, you have been doing this for almost 24 years now.
Yep.
What are the different types of bariatric surgeries, and then we're going to go into specifics.
Of course. So bariatric surgery, of course, as we've said many times, is the most effective treatment we currently have for severe or morbid obesity. When obesity has gone to the extent where there is really a risk of the development of several illnesses related to obesity that could be life-threatening, whether it's diabetes, high blood pressure, sleep apnea, or the really development of different cancers, which happen to really find a fertile ground in obesity. So when obesity gets to those levels, and typically we're talking about somebody who's 80, 90, 100 pounds or more above their ideal body weight, not only there is this risk of these illnesses, but it is extremely difficult to get rid of the weight without an effective treatment like bariatric surgery. Bariatric surgery now is a very well established, safe treatment that is really advocated by doctors in the United States when their patients present with extreme levels of obesity.
So I'm running a video for people to kind of see different images. Obviously, we may not be on that specific type while we are talking about it, but that's going to run in a loop. We want to probably start with bypass first.
Sure.
What's bariatric gastric bypass? What is that procedure? Who should be getting it? What's the best candidate for that? We can start with that, and then we'll go to gastric.
Absolutely. So all bariatric procedures of surgery entail some kind of change to the upper portion of the digestive tract. And we're talking about the food pipe or the esophagus, the stomach, and the early portion of the intestine. With gastric bypass, what we do essentially is we partition the stomach. We divide the stomach between a very small portion still attached to the food pipe and the rest of the stomach. And we separate these two portions of the stomach completely. And then to restore continuity so that the food that comes from the food pipe into the little stomach can get into the rest of the intestine, actually we reroute the intestine and we attach a portion of the intestine to that little stomach, bypassing the larger stomach and the early intestine. That's why it's known as gastric bypass. Gastric bypass really has been established as the gold standard of bariatric surgery because that's the one that we have developed for many years. In fact, early in our career, about 22 years ago, gastric bypass was the procedure we did the most. Okay? It's a very effective procedure. It has excellent results, and nowadays it can be done laparoscopically. In fact, in our center, very often we do it as a day procedure where patients come in, have gastric bypass, and go home at the same time. Right? Excellent results. And really, anybody who has morbid obesity could be potentially a candidate for this very well-established procedure. However, gastric bypass really has been pushed aside a little bit by the arrival of another very powerful procedure, but less invasive procedure, which is the gastric sleeve. So although the vast majority of patients who have morbid obesity could be candidates for the gastric bypass procedure, we don't necessarily offer the gastric bypass as the first line procedure. We offer them the gastric sleeve. The gastric sleeve is less invasive than the gastric bypass.
Just before we go to that, with gastric bypass, what we are saying is you're a young person, let's say, and you don't have diabetes, like severe diabetes, you don't have refluxes, and also we do EGD to see if there are issues, structural issues in the stomach. So, and if there is no clinical need for you to have a bypass, you should not get a bypass as your first option.
Totally. Right. I think that's a fair statement, Kemal. I mean, clearly all procedures are appropriate because they're well established, right? But really, if somebody can do the same, can get the same results with a less intrusive procedure, right? Like the sleeve, there is no need to go with the gastric bypass, right? So there's no really need to do a very long run for a short jump, as they say, right? The gastric sleeve, in the vast majority of times, can give the same or similar results to the gastric bypass to the vast majority of patients who are looking for bariatric surgery, and therefore we don't necessarily offer the gastric bypass as a first-line treatment. Clearly, I want to state here, Kemal, that the choice of procedure is something that should be decided between the surgeon and the patient. It's not something we prescribe necessarily, but it is our job, obviously, to inform patients with our knowledge based on years and years of experience, having operated on thousands of patients over the time. So, for somebody who has morbid obesity, as you say, they don't have severe reflux, gastric sleeve will absolutely do as the first line procedure, and it will give the similar results to gastric bypass. Now, it is important to clarify the issue of reflux here, Kemal, because yes, there is some truth about reflux and the need of gastric bypass, but a lot of what is talked about is actually a myth, right? Somebody who has some reflux would come to our office saying, I can't have the sleeve because they read something about that online, right? Mm-hmm. It is not true. The type of reflux that would negate the gastric sleeve is really severe type of reflux that really affects only a very small minority of patients who have reflux symptoms. And that is something, obviously, that we diagnose after we do endoscopy, which is one of the preparation procedures that we do before bariatric surgery. So it is really fair, as you stated, Kemal, that the vast majority of patients will do absolutely well with the gastric sleeve as the first line of treatment, right? Now, who are the patients on whom a gastric bypass might be based? Well, these are a minority of patients, for instance, that would have very severe reflux. And some bariatric surgeons also feel that patients who have a very difficult to treat diabetes, right? Diabetes, which is really difficult in its response to medications, those patients might be better with the gastric bypass because gastric bypass definitely has an edge in its impact on the resolution of diabetes when you compare it to gastric sleeve. Again,
So it's when we are not able to manage it with medication. Like I see some patients who have reactions to like metformin, so they're not able to take it. They try different things and it doesn't work for them, and then A1C is still high. So that in those cases, this would be the right way to go.
absolutely. So we're talking again in a small minority of patients. Again, it's not all patients with diabetes, but again, patients when they come to my consultation, very often they are very happy to listen to my advice, my experience based on what I've done, and they will ask questions. But there may be some patients on whom certain ideas may be so set based on experience through family members and friends. They may say, you know what, doctor, I just want the bypass. And if that is the case, absolutely. These are procedures that are appropriate for all patients requiring bariatric surgery. But as we mentioned earlier, the vast majority of patients will do well with the sleeve. Now, it is important, just like I described what the changes were with the gastric bypass, that we describe what the changes are with the gastric sleeve as well, right? With the gastric sleeve, the main difference is that the intestine is left in its natural place and situation. We don't reroute it, we don't cut it. All the surgery is focused on the stomach itself, that larger organ. And what we do essentially with the stomach is we divide it so that the stomach, which is naturally the shape of a watermelon, when we're done with the sleeve, now has the shape of a banana. It's much slender, it's much tubular. The larger distending portion of the stomach is the portion that you see. Now, it is definitely true that a lot of the results from the sleeve come from the fact that now the stomach is small. It doesn't have a lot of volume. Therefore, when the person eats after they've had the sleeve, they will feel full early and they are going to be hungry less frequent. But there are other effects of the gastric sleeve as well. By removing the portion of the stomach which is distensible, we're actually removing a metabolically active portion of the stomach that communicates with our brain to promote storage of fat, right?
And
so by removing
many
that,
people don't understand that, right? So when we say we are cutting part of the stomach, so they're like, so what, right? That's not so what. So that part is the part that communicates with the brain.
absolutely.
It's almost, it has its own personality. Like they kind of just,
they do. I mean, the gut is known as the second brain because it is so much more involved in its communication with the brain, and rightly so, because our digestive tract is so critical in our energy balance. But the way how our body has evolved, essentially, it favors storage of fat, right? Our body is not designed to lose weight. It doesn't know how to lose weight, right? It knows how to gain weight, but it doesn't know, right? So all the systems are really optimized for storage of energy, which means for increasing weight. Once we remove
I have a picture right now, Dr. Irgau. I don't know if you're able to. See, I stopped the video for a second just for because I want people to really understand this. So this comes up as a question from patients and from others, from providers, from physicians as well. So the part that we are removing is the part that makes us hungry. That's right. As it happens, the picture we have here is actually the sleeve plus the vaginal switch. So I don't want people to get confused because there is rerouting of the intestine as well. So if you have one where we just have the removal of the, and I think you had it a moment ago. I have it. I mean, this as you're correct. When you look at the stomach, that's essentially how the stomach is divided. But this is showing the sleeve plus the vaginal switch, which is obviously a different procedure. But it's coming. But the idea again is that a portion of the stomach that we're removing is not just food storage portion of the stomach, but it's also a very active portion of our organ that once it's removed, it deprives the body from its mechanisms of fat storage. That's why it's so much easier to lose weight after the sleeve is done, for instance, as opposed to a diet
that gives you an equal amount of calories, right? You can decrease your calories with a certain diet, but you know that after a while, the weight loss stops. It's not the same thing with the sleep because, yeah, absolutely.
It's kind of like the picture is not the best one. I'm going to get a better picture for us.
Absolutely. So essentially, by removing that distending portion of the stomach, we are making the person metabolically different from what they were before, right? Now they are able to lose weight. The body is much more permissive about weight loss. That's why they are able to do that. So metabolically, we can become much healthier now because not everything is geared towards weight gain. Everything now is much better balanced. That's why people are able to lose weight. So it is important to emphasize here that the results from the gastric sleeve are not just purely mechanical, but they are metabolic as well. And what does that also mean? Well, it also means that there are benefits just that go beyond the weight loss as well, right? We mentioned earlier on that the gastric bypass does wonders when it comes to improving blood sugar control, right? Getting rid of diabetes. The same thing happens with the sleeve once the weight loss starts happening as well, right? Patients who have high A1C can have the sleeve and the A1C can be reduced. The A1C is one of the indicators of diabetes, essentially. Similar things happen to other metabolic diseases as well. So in essence, we can look at the different procedures that we have right now, Kemal, and really gravitate around the sleeve as the main procedure to offer to most people, although the other are available as well. In other words, and it's also, that's also the reason why in the United States, almost 75% of the procedures done are actually sleeve gastrectomies. And intuitively, most patients also choose the gastric sleeve as their procedure of choice. Absolutely. So now
I have to kind of customize it a little bit so that the resolution.
Yeah, absolutely. So what you're showing essentially now is the stomach that has been reduced to the shape of a banana, right? The stomach that was much bigger with a distensible portion on its side. Now it's much slender, and that is the result of the sleeve. And as we've mentioned in other sessions, when we call this procedure the sleeve, some people have this idea in mind that we are putting a sleeve over the stomach or we are putting a device.
I remember in the beginning, like several years ago, I thought you were actually, once you cut it, you were actually
wrapping with something.
It, so that made sense with the sleeve, but then later on that was kind of...
So there is no device that we place. It's basically surgical removal of a portion of the stomach. And the simplicity of that procedure also is seen in the decrease in potential for complication for the surgery itself. In fact, it's no surprise now to see that a gastric sleeve done laparoscopically has the same safety profile of, let's say, a gallbladder procedure or an appendix or a hysterectomy.
It's almost now 6 years that we do this in an outpatient setting.
Absolutely.
And 99.5% of the patients are being discharged 6 to 8 hours after their procedure. So yes, from safety standpoint, but also what makes that safety great is our program.
Absolutely.
Because of the patient selection and what we have to go through, prep the patient in terms of getting all the clearances done, their nutrition classes, following up with surgeons in between necessary clearances, and having a care coordinator who's a nurse is with the patient for the entire time. That actually makes it, of course, safer, obviously. But yes, this is the same procedure.
Absolutely. So really, because of all these features, the gastric sleeve almost by default has established itself as the to-go procedure against which all the others have to be measured because we're doing so many of them, right? And then the other thing which is very important for people to understand is because we're not cutting the stomach completely away from the food pipe, the digestive tract is still accessible for us to do endoscopy. For instance, if you do the gastric bypass command because you're really interrupting completely the succession of the stomach itself, the early portion of the intestine after the gastric bypass is not accessible to endoscopy, right? You cannot go into the lower portion of the stomach or the early portion of the intestine with an endoscope through the mouth, you cannot do it because it's been interrupted. Well, the gastric sleeve still allows you to do that. And then the other important difference also with gastric bypass is because we're not manipulating the intestine, there is no risk of twisting of the intestine, which can happen with the gastric bypass, essentially, because
Those are the complications.
these are potential complications that could be there for life. So if you have a 24-year-old patient who's suffering from morbid obesity, really you have to find a very, very good reason for them to have bypass as their first choice, really, when the sleeve can do a similar job, essentially, right? And then the other thing I tell people also is that with the gastric sleeve, you still have options later on if something needs to be done surgically. Whereas with something like the gastric bypass, you're almost doing a final stop procedure where really maneuvering is not there for surgeons to do other things if that were to be necessary. So these are important. So not all bariatric procedures are equal in that sense. Yes, we have to talk about all of them because all of those procedures are available and there are individuals who clearly would benefit one from the other. And that individualization, Kemal, is best done at the time of consultation and evaluation because every patient will come with their own version of their own history, with their own indications. And there may be situations clearly in which the bypass may be better than the sleeve. So we have to be able, as a full bariatric program, we have to give all the options, and ours, obviously, we are able to give the gastric sleeve, the gastric bypass, the duodenal switch, the gastric balloon, the lap band. All these procedures are available in our practice. All our surgeons are really very much experienced in the provision of these procedures. But just because these procedures are available, it doesn't mean all of them are equally pertinent for all patients, right? So it is reasonable for us to say that the vast majority of patients will do very well with the gastric sleeve, which is much, much more powerful than a weaker procedure, which is the lap band or the gastric balloon, but it is also much less complex and has less potential complications long-term than the gastric bypass or the duodenal switch. So it is a good, solid, middle of the road procedure. It's reasonable for us to really.
Like the way that I see, because going through the case conferences every day, dealing with so many of our patients, like I have a, like I'm not a surgeon obviously, so I have a different advantage though. I kind of see patients from the same format, like the way that we design our care coordination process, case conference process is that I can kind of easily see what's wrong, what's right, what's wrong, and I can easily point out certain things that are right or wrong for the patient. And that's why sometimes we actually go back to the patient and say, oh, hey, you're a 25-year-old bypass, you want this, and maybe our surgeons didn't want to be pushy, but here, watch these videos and make the decision because this is not the right way to go with you. But what I was going to say that if the compliance and commitment, if it's there, gastric sleeve is going to work.
Yes.
I do different trials for the compliance. So, with these episodes, I have to just give away a lot of personal information, but it's in some cases we do to understand what patients are going through. There was a patient that we put that patient for 3 weeks Robart for 2 times. This patient BMI was very high. And I said, well, is this even doable? Now, I did, as you know, Robart time to time to see, if it's tolerable, like can I eat it? Well, there's one product that I like a lot. So then I almost, in some, last week actually, I ate it as a dessert because I was going to either have ice cream or just, mix the pudding and put half banana in it and then put it in the freezer for 90 minutes and then here's your ice cream, so, and healthier. Now, what I see is the compliance is the problem. So, like, when I was doing the robot, I was still having a light lunch. It was almost like lunch plus robot to not to overeat, but that was not helping. When I'm just eating robot, which I'm doing that this week, it works.
Yes.
It works. If you can stay and not cheat,
Yeah.
it works. Is it doable? Like you have to try and then make certain adjustments. Like this week I did. I was doing like one portion at lunch, and that was forcing me to eat something else. But now I'm having two of them together. Boom! It just cut me on for 6 hours until dinner. Now, in fact, the last 2 nights, I couldn't eat more, and I had to switch to salad. So I made some greens and I boiled like 3 eggs, and look, I mean, it's a good replacement. It works. And then Friday, like this is from Monday night to Friday morning, I can feel it. That means if someone who's at 390 pounds, that person is going to feel it much faster and much. There will be a much bigger success of the weight loss. So commitment is the problem in many cases, because I don't want patients to think that, hey, I'm going to do this and I'm going to do that if this doesn't work. No, that shouldn't be. If you put the commitment into the gastric sleeve, it is going to work.
Yes.
That's that simple.
Yes.
Right?
Yes. Yeah, absolutely. As we always say, these are tools. They are very powerful tools, but they are tools nevertheless, right? Now, what is then the bigger difference, from dieting versus doing surgery if you're still going to be disciplined? Well, because with dieting, no matter how disciplined you are, it just doesn't work, right? You stop losing the weight at a certain point, and then it's very easy for the weight to come back. Well, these tools actually are very, very powerful, right? They are powerful, but they are not infallible, and that's what we want. So there used to be a bariatric surgeon who's now retired, Kemal, who said, you can out-eat any bariatric procedure, right? And he's right, you can do it, right? Even though you don't have a big volume right now and you cannot eat a big, large meal, if you eat M&M all day long, right, then you will have enough calories for the weight to start going up, essentially. So that basic level of discipline is clearly very important, right? And of course, being active physically is very important. And many of our patients cannot do a lot of physical activity because the weight holds them back, right? There is pain on their knees, there is pain on their back, they get short of breath very easily. So it is very, very difficult for them to do any meaningful type of exercise. But as they start losing weight and they feel more energetic, we want them to make exercise a part of their routine because they cannot afford not to be active. That's the key issue, right? Somebody who's thin all their life, bless their heart, they've had good genes. There is a minority of people who are like that. They can eat whatever they want. They never work out and they're always thin. Well, that person can afford maybe not to be active. But somebody who's struggling with weight, once they acquire this tool and they start becoming thin, cannot afford to let that opportunity go without exercising. They have to make it part of their life. They have to engage in hobbies that will make them be physically active. That is very, very important. That's why bariatric surgery is not something that we throw away on 1 week and leave patient. We forget them. No, it's a commitment that requires foundational changes in lifestyle. And that's why our preparation process is also so extensive. And also follow-up is long-term. We want the patients to follow our practice in the long term as well.
One of the things, sometimes, what we are saying here is like being able to do certain things, right? So, I entered into a tennis tournament this week. But I didn't play for almost 4 weeks because I was in Turkey, and then I missed 3 Saturdays in a row. And then after I came back, I play on Saturday, and then the heat, it was excessive.
Yeah.
Played on Sunday. Now Monday, the match started after 10:15 p.m.
Okay.
So that's way after your bedtime.
Bedtime, that's right.
So I would never call you at that time if I had emergency, right? So. And I have kind of weigh and kind of see how I feel. whether or not I could do it. Now, with this, I was able to do it. I mean, we lost big time, but that wasn't because of the weight issue. It was just they were better players. But the thing is, I was able to do it. I mean, it's 1 hour. They beat us in 2 sets, but I was out there to play 1 hour. Now, did I suffer a little bit next couple of days? Yes, but that's what it is.
Yeah.
But what we are saying here is, for even the regular exercise, like being able to walk 20 minutes, when you are 380 to 400 pounds, that's not easy. So that's why we are saying that the commitment with follow-ups, with diet, and changing the approach, the way that we eat and the way that we exercise is kind of are the key factors here. So regardless of which surgery type we are going to, we want to make sure that we prep the patient for the right one. The right one is based on the clinical conditions. If they don't have any other indicators, that sleep is the go-to procedure. Now, I want to talk about a little bit on the revision. So, and maybe before we talk about revision, if we can kind of briefly explain gastric band, because that was one of the earlier procedures, less invasive. So it was kind of like people who didn't want to take risk in their mind. We went with that long time ago, and we haven't done too many of them these in the last couple of years. If we can kind of go through the band a little bit, and I have the revision follow-up.
Yes, I mean, it's a procedure, as you correctly said, that we used to do a lot more about 12, 15 years ago. And the appeal of the procedure was its simplicity and the fact that it didn't require any permanent cutting of the digestive tract. Essentially, it's based on the fact that we put a little belt around the upper portion of the stomach, just very close to the food pipe. And that belt can be tightened after the surgery without repeating the surgery, the so-called band adjustment. And what happens essentially is because of that tightening, people will feel full early and they're not going to overeat. And for some patients, it worked very well. There are some patients on whom we placed the band about 20 years ago, and they're still keeping their weight. But many patients have had problems, particularly with quality of life, because it was very difficult for them to predict whether they were going to be sick after they eat or not. So repeated, situations of sickness. But also, many patients didn't do quite well in terms of the weight loss. So the results were weak from that point of view, particularly for patients who needed to lose 100 pounds, 120 pounds, essentially. So what happens is many patients who had the band had to be removed, but they were still left with the fact that the weight came back, or, they had significant weight gain even when they had the band, because the band had to be loosened. So we had to offer them a different procedure. And when you go from one bariatric procedure to another, it's called a revision, right? Some people think of revision as a dirty word, but it's not. It's a completely bona fide thing that surgeons do. We do it for many types of treatments. If there is somebody has a cancer and we do a procedure, we may need to repeat that procedure in a different way, either because the cancer has come back or there are other issues. So doing repeat surgery is appropriate in certain circumstances, and bariatric surgery does not have to be any different. And the reason I'm emphasizing this, Kemal, is that we come across some absolutely unreasonable insurance plans which say you can have bariatric surgery only once in a lifetime, as if it was a trip to some vacation place that they had to win, instead of looking at it as a very important medical treatment. They say you can have this procedure only once. It doesn't make any sense, right? People should not be curtailed in the availability of treatment. So when we do a bariatric procedure the second time
It's
round,
almost like you can only have diabetes medication for
12
months.
Exactly.
After that, you're on your own.
You're on your own. It makes no sense at all. So when a particular bariatric procedure hasn't worked well for a particular individual, and this can happen, it can happen in many types of treatments, then we look for a different procedure, which means we do a revision. So we've done revision, for instance, for people who had the band either it didn't work or the band gave them complications. So we remove the band and we do another procedure. Now, it requires good experienced bariatric surgeons to do revision because revisions are more difficult in that you're working on tissue that has had scarring in it, and then working with scar tissue is, requires more expertise. Essentially, the complication rates can be higher than working with what we call virgin tissue that didn't have any previous surgery. But it is something that we do and offer in appropriate settings. Now, revisions can be done after the band, revisions can be done after the sleeve, but some revisions can be done even after gastric bypass or the vaginal switch, although much less commonly because the anatomy itself is much more final in the way it's done when you do a gastric bypass and the vaginal switch.
So the revision, the reason I wanted to mention that is because I see that more often these days, a lot of patients after gastric band, now if they haven't got to a point where they lost enough weight, they're coming back. For those, as you mentioned, we would
Sorry, but
we would first remove the band, and then 6 weeks later we would schedule their either gastric sleeve or gastric bypass. And if we are familiar with the patient, depending on what they went through, there will be less need for certain clearances, but we still want them to go through their nutrition and psych and other stuff.
absolutely.
And we also do gastric balloon.
Yes. Thank you for mentioning that.
Sure.
Yeah.
And gastric balloon is one of those procedures. It's not covered by the insurance. It's a self-pay procedure. The best way to kind of explain when would be the right time for it is someone who's let's say BMI 32 and they have their daughter is getting married, and then you need to lose 30 pounds in 6 months. That's your procedure. So, but from the clinical side, you can.
Yeah, absolutely. So essentially, as you say, the gastric balloon is actually the least. Sorry about that. The gastric balloon is the least invasive procedure, and simply because there is no cutting on the skin, there's no incisions, right? It's all endoscopic, which means we enter the stomach through the natural opening, which is the mouth. The person is asleep, and we go with a little camera into the stomach, and we are able to deposit a big balloon into the stomach. Now, this big, heavy balloon inside the stomach creates a sensation of fullness on a permanent basis. Morning, lunchtime, dinner time, nighttime, the person is full because this big balloon is there. The other effect of the balloon is it tends to slow what we call gastric emptying. The stomach doesn't empty quite as quickly, so even the little amount that the person will eat will not leave the stomach quickly, so they will feel full really for a prolonged period of time. That's exactly how it works. The issue, as you correctly said, is that the balloon cannot be left inside the stomach indefinitely for two reasons. One, it can actually damage the stomach wall after a long period of time, but also the stomach itself can degrade the balloon itself, right? So the time in which the balloon can stay in the stomach is actually 6 months. So people have 6 months in which they need to lose their weight. Although in our program, if somebody enrolls in the gastric balloon program, we have them actually see us for 12 months. The 6 months in which the balloon is in place, but also we have them seeing our nutritionist for another 6 months after that to try to preserve some of the good habits that they have learned when the balloon was in place. Clearly, not everyone is a candidate for the gastric balloon. The best candidates are actually people who have a body mass index between 30 and 40, and that's really the main indication. And again, they have to understand that the period in which the balloon will be in place is limited. And the other challenge, obviously, as you mentioned, is that it's not covered by insurance. So patients have to self-finance it either fully by themselves or going through some financing arrangements. But we are obviously able to offer it in our surgery center.
So at the end of the day, bariatric surgery is a life-changing decision. And understanding your options, knowing what you are getting is crucial because we want you to get the best possible outcome. Listening these episodes other than your consults with the surgeons, I believe it's going to be extremely helpful. And that's why we are doing these episodes for our patients and those who are looking for different options, and hopefully we are able to make an impact on their life, and they can make the right decision for themselves. So, Dr. Erkan, thank you so much for joining us again today. It's special for us because it's the first time we do this in the same room. It feels different,
It's great. It's great.
So I'm glad we are able to do it, and again, thank you for joining us. So have a great weekend, and we'll see you next week.
Thank you.